All right, good evening, everybody. If you are in your evening, if you're in your morning, good afternoon, wherever you are. Thanks for joining us. It's a pleasure to be back. Today we have the first, hopefully of a few, but the first of our resident case reports. Fantastic, and we are honoured to have a very brave resident here, exceptionally smart for being a resident. Constantly challenges me, and I
not difficult.
Not difficult, but I often have to ask him questions. I've never met anyone who knows the literature as well as this guy. So it's a pleasure for me to introduce Koen Santifort, Dr. Koen Santifort. Did I do an okay job there? Because it's going to get worse from now in introducing you. Dr. Koen Santifort is a first-year neurology resident at a practice in the Netherlands, and here goes. It's Evidensia, Hart van Brabant.
Great.
Is that in a municipality in the Netherlands called Waalwijk? Is that okay?
It's
typical English person speaking a foreign language.
Don't get me started, Laurent. I'll start French any minute. Fluent. And his mentors, people he works with, are well known in the neurology community. But I am going to do a very poor job of pronouncing their names. I apologize to everyone in advance. Nicholas Bergnut, Iris van Soens, and Paul Mandigus. Hopefully it wasn't too bad in the municipality of Waalwijk. Okay, I'm enjoying that, actually. It's so bad. Anyway, sorry. Cool. It is a pleasure to have you on, and we do believe you to be very brave to do this, because this is the first of our case reports, but there's no pressure. There's just several thousand people watching.
The internet won't fail me.
Good. But you do have a fascinating case to present here and review the literature. And so we believe you are a great person to get this started. Hopefully then when you're done, we'll hand over to Laurent, who'll still be with us because he's on his non-alcoholic beer binge, and he can see if there's been any questions. But so without any further butchering of many languages by myself, I'm happy for you to take over the screen.
That's no problem.
Good luck.
Thanks. Can you see everything all right? Okay. So we're going to start with this case presentation here, and I'm very honored to be the first resident to try. I hope you can all hear me, and if you're thinking, why is this guy so close to the screen? That's because my microphone is integrated into the laptop. So anyway, we're going to talk about a trigeminal neuropathy with a twist. So wait for the end, otherwise you'll miss it. So this is Ellie, an 8-year-old female neutered American Staffordshire Terrier. And she was presented with an inability to close the mouth. She was producing excessively thick saliva, the owners noticed, and difficulty eating, obviously, if you can't close your mouth. Polydipsia, they noticed that as well, but otherwise there were no general illness signs. The owners were kind enough to provide me with lots of images, just to show you how the mouth was hanging open all the time. And in the hospital, we encountered a very active and enthusiastic dog with a non-remarkable general examination. The neurological examination was basically normal on a lot of points, but obviously the posture, if you will, it caught my eye that there was a dropped jaw, and the cranial nerves showed several deficits, which we can see now. And on palpation, if you want to palpate the jaw tone, you can do that safely in this dog because he had none, basically. So what about the cranial nerves? First off, all the other ones that are not mentioned here were basically normal. The trigeminal nerve, we noticed that the palpebral reflexes were intact, but a little bit weaker upon stimulation of the lateral canthus of the right palpebral fissure. And there was loss of masticatory muscle tone, which was most prominent. And there was a decreased response to pinching in the lips and stimulation of the nasal mucosa. The facial nerve, well, the palpebral reflex is as above, but there was also thick foamy saliva in the corners of the oral cavity, and I'll come back to that later. The same goes for the glossopharyngeal nerve, because both of these are actually responsible for producing that saliva. And regarding sympathetic innervation of the head, there was anisocoria, mild miosis of the right eye or right pupil, ptosis and protrusion of the membrana nictitans. So our main findings of the cranial nerve examination were masticatory muscle tone decrease and facial nasal sensation abnormalities, that's the trigeminal nerve, salivation, as I said, facial and glossopharyngeal nerve, and a partial, if you will, Horner on the right side, sympathetic nerves, and you can see that in these images over here. Especially note this thick saliva in the corner of the mouth, which you could draw a strand of like 20 centimeters before it even broke. So that was pretty eye-catching. I just would like to point out for all the residents listening that there is a really cool website by Simon Platt and colleagues of the University of Georgia, which displays basically very nice images of all the cranial nerves, and you can use that to study them, their anatomy as well as their function. So I incorporated some of the examples here. You can see the afferent pathway for the lip pinch test, which is the trigeminal nerve, and the efferent pathway, which is the facial nerve. And they have really cool slides that depict all the central nervous system components that are involved in this reflex pathway, but also for all the other cranial nerves, as I said. So really good to take a look at that if you're interested in getting a more clear picture about those reflex pathways. But anyway, back to business. We got a drop jaw in this dog, which means that there is bilateral dysfunction of the trigeminal nerve, and it was acute sort of a week ago. What are our differentials? Main differentials are idiopathic trigeminal neuropathy or trigeminal neuritis, which could be infectious or non-infectious. Neoplasia, infiltration of the cranial nerve, the trigeminal nerve, but it would have to be bilateral, because if you only lose it on one side, you should be able to close your mouth. So that could be lymphoma or other round cell neoplasias that invade that area. Polyneuropathy or polyneuritis cranialis, which has recently been a term that's thrown into the veterinary literature, could also be myo-associated, so meningoencephalitis of unknown origin. And theoretically, hypertrophic pachymeningitis would also be something to consider if you have multiple cranial nerve deficits. Looking at what we did in this dog, we did several diagnostic tests. We did biochemistry and hematology, which were not remarkable, magnetic resonance imaging of the head, CSF analysis, and electromyography of all the masticatory muscles. So we sent the study to Vet Oracle, and Vet Oracle reported on it. And they remarked that both trigeminal nerves were enlarged at the level of the mesocephalic aqueduct. Ganglions were enlarged as well. There is also contrast enhancement of those trigeminal nerves, of their roots and the nerve itself as well. If you can see that here on this parasagittal image, I hope you could see the cursor as well. You can see that over here. And just on the point when the nerve root attaches to the brainstem, you could see that on this transverse image and on this dorsal image, you can see they really light up. There was also something different to see, namely the parotid salivary glands, which you can see here with these arrows. There was atrophy of both these glands, and there was T2 and T1 heterogeneous hyperintensity in those glands. The other glands, the largest ones, the zygomatic and the mandibular glands, were unremarkable. As I mentioned, we also did electromyography of the masticatory muscles. The masseter and the temporalis both showed fibrillation potentials, increased insertional activity, and some positive sharp waves, as you can see on this video over here. So that would mean denervation or maybe muscle pathology, etc. CSF analysis, as I mentioned, protein was above reference, as you can see. No nucleated cells. There was some blood contamination. So we can conclude that this is albumin-cytologic dissociation, because there is no increase in nucleated cells, but there is increase in protein. And PCR for infectious disease was all negative. So can we conclude on a diagnosis right now at this point? We could say that most of those differentials we reported on earlier are crossed off. We're left with idiopathic trigeminal neuropathy, which is also called in literature trigeminal neuritis or idiopathic trigeminal neuritis, and sometimes trigeminal neuropraxia, but that suggests that there is trauma, and we have no indication that that was the case in this dog, but we cannot really exclude it. Or trigeminal neuritis per se, so really inflammation of that nerve, but it's usually a diagnosis you would only be able to confirm on pathology. You could argue to include neoplasia here as well, but that's really a bit of a stretch with these findings. What about the twist, the salivation abnormality? Can we explain that? Does the trigeminal nerve have anything to do with that? Earlier we concluded that should be the facial and glossopharyngeal nerve, so that's still a question mark, and we'll come back to that later. Let's first dive into the literature, because we have to explain some things. Well, I find this a really nice case report from India, of all places. We don't see a lot of literature coming from there, but it's worth to take a look at, because this was a case report of a dog with traumatic origin for its dropped jaw, and the authors reported on an owner basically prying the jaw open and feeding it, or pouring water into it, because that was what he wanted to do. And straightly after that, there was hanging of the jaw and the tongue going out like this. So our conclusion would be, don't do that. There are larger case series, if you will. This was the largest one up until recently on trigeminal neuropathy in dogs, about 29 cases. There were some really interesting conclusions, namely that sensory innervation or deficits were observed in the minority of cases, but still some. Facial nerve deficits were also observed in 8% of the cases, only 2, and Horner syndrome the same. They did electromyography of some of those patients, and they also saw abnormalities in 7 of the 9 dogs on which they performed that. And cerebrospinal fluid analysis was also abnormal in 7 out of 8 dogs in which they performed that. And I forgot to underline it, but corticosteroid therapy did not affect clinical course of that disease. There is a recent case report from France with all of these authors, I think French, and they reported on 49 dogs with either idiopathic trigeminal neuropathy, neuritis, or neoplasia. And they concluded some stuff that's useful in the clinic, namely that bilateral trigeminal dysfunction, those dogs were really likely to have a diagnosis of idiopathic trigeminal neuropathy with a probability of more than 95%. But these authors had some criteria for diagnosis of these 3 things. For neuropathy, they conclude that, well, if you have no abnormalities on the MRI and if the contrast enhancement of the trigeminal nerve or nerves is less than that of the pituitary gland, they based that on some earlier literature, then you have a neuropathy. And this case is a unilateral neuropathy where they didn't find anything abnormal on the MRI except for the masseter muscle atrophy. Neoplasia, they concluded neoplasia if there was an enlarged or bilaterally enlarged trigeminal nerve with a marked contrast enhancement and mass effect. And the mass effect is the important thing, because in the neuritis, they also had to be enlarged. There also had to be abnormal contrast enhancement and no mass effect. So the mass effect is the differentiating thing for them between neoplasia and neuritis. But you can argue that that is a bit shaky, maybe, because they didn't have pathology to distinguish between those different types. And, well, neuritis, neuropathy, can you really conclude that it's a neuritis if you don't have pathology? That's maybe a little bit tricky. Would be nice to have the pathology to confirm. They included a graph that if you have a dog which is young, it's most likely to have idiopathic disease, and the older it gets, basically the probability of neoplasia increases. And if you have, or if there is sensory impairment, you are less likely to have idiopathic disease, in this study at least, because in the other study I mentioned 35% of the patients had it. But you're more likely to have neoplasia or neuritis. And if you have unilateral clinical signs, you could have all of these things a little bit less likely to be idiopathic. But if you have bilateral signs, you are likely to have an idiopathic neuropathy. One of the downsides was there was no information on treatment or evolution or regression of the deficits in these dogs. There's also a recent case report on 3 patients with bilateral cranial polyneuropathy, which was also termed polyneuritis cranialis, and that was associated with meningoencephalitis. And these authors also encountered some trigeminal nerve abnormalities on their studies, but also a lot of other abnormalities. So not only the trigeminal nerve. If we dive into the literature on MRI specifically, we can find a lot of interesting stuff. So this is a case report where the authors reported on trigeminal nuclei abnormalities on the MRI scan of a dog with idiopathic trigeminal neuropathy. And in this image, you see the transverse T2 flare and hyperintensity here, on the border of the brainstem at the region of the trigeminal nuclei, and also enhancement of the trigeminal nerves themselves and the ganglia. But if we look at the anatomy, it is pretty difficult to state that, or at least in my opinion, that these are definitely the nuclei, because if you reference that to some atlases that can be found on the internet, then you can see here that the trigeminal nerve root is very close to the brainstem and the nuclei associated here. This is a slightly different level, so I'm cheating a bit here, and if you go a little bit more coldly, they are right to conclude that the spinal tract, at least, of the trigeminal nerve is in that neighborhood, and some of the nuclei here as well. But again, there was no pathology in this case, so to conclude that it's abnormal in the nuclei would be best to have pathology, but it's nice to see that there are some peculiarities in cases of idiopathic trigeminal neuropathy on MRI sometimes as well. Other studies, magnetic MRI of acquired trigeminal nerve disorders in 6 dogs. They reported on several diseases with neoplasia, which has a clear mass effect here, but also less clear cases where there is unilateral enlargement with more contrast enhancement than on the other side. And there was a study on magnetic resonance imaging enhancement after contrast without evidence of neuropathy. And basically they found that there is, in normal dogs, also contrast enhancement of those nerves and nerve roots or ganglions, and the roots they didn't specifically mention in this report. There was another report that aimed to describe the differences in contrast enhancement in several regions of pituitary gland, meninges, but also the trigeminal nerve and the root, but not the ganglion in this case. And they found that the trigeminal nerve showed the most enhancement, so more than the pituitary gland, in contrast to earlier studies that mentioned that the pituitary gland was always more than all the other structures. So that's a good one to keep in mind, that if you find contrast enhancement, and even if it's pretty remarkable, it might not be abnormal per se. What about this case? You can see the images of this case here. This is the T1 before contrast, and you could do a measurement on the signal intensity in that case, and it doesn't mind if you window it, it stays the same, so it's an absolute measure. This is 1 minute after contrast, and we see a significant increase in the values. 6 minutes after, we also did a sequence, and we saw a slight difference, but that's, well, it's one case, so if it's significant, I don't know. On the flare images, it's less conspicuous, and on the 17 minutes 3D T1 post-contrast, there was less enhancement absolutely measured. So in this case, also fairly shortly after administering contrast, the signal intensities were greatest. And they also concluded that, or this study concluded that trigeminal nerve enhancement is a normal finding, also without trigeminal nerve disease. And they tried to explain it by postulating that the vascularity or the dependency on the basilar artery in that region is great, and that would account for more contrast than in other brain regions. But that's just theoretical. There was also a recent report on low field MRI measurements of the trigeminal nerve, because can we say it's enlarged only subjectively, or can we measure it? That was basically the point. They did that in normal canine trigeminal nerves to establish some sort of reference guidelines. They mentioned that there were ratios you could measure, so you can measure the whole brain on transverse and then the trigeminal nerves as well, then take a ratio out of the height and calculate. And they found maximum ratios in normal dogs of 0.13, and in this case it was only 0.10 or 0.11. So on the ratio, it wasn't really enlarged. The width is measured on the dorsal images, and that was borderline normal. The maximum value they measured was 0.14, but the median values were less. If you look at the absolute values, they seem to be larger than what was reported on the mean measurements they did in these dogs. So even in large dogs, they were a mean of 4.6 millimeters, and they're above 5 millimeters. So that's a good thing to note, that the absolute values in this dog were bigger than the means in those studies. This was just a slide to show you that those measurements are easier said than done sometimes. This is an MPR of the trigeminal nerve, so you can see the slice thickness over here between the dotted pink lines. And this is the dorsal line, so you can see the whole nerve here. And you can do some measurements here. In this study, they performed the measurements in this angulation. And in my case, it seemed like the trigeminal nerve took a little bit of an S-formed track, so it was difficult for me to establish the right level to measure this length they did in their study. So I'm not really sure if that's comparable. Also, on the parasagittal image, which they didn't use in that study, it was really good to see that the trigeminal nerve in my case was at least subjectively pretty large and almost 6 millimeters in thickness. And you can see it nicely attaching here to the brainstem and going out through the canal here. So what about the twist? What about the salivation? That's an important one. So there is actually, to my astonishment, a very recent report that titles exactly what I was looking for: a salivation abnormality with trigeminal nerve dysfunction in dogs, authored by some really well-known neurologists. But it was in a dentistry journal, so not a lot of neurologists would come across that by happenstance. You have to look for it. So I fortunately looked for it, and they reported on salivation abnormalities. So the same thick, whitish saliva in the backs of the mouths of these dogs at the ends of the ducts of the parotid gland and the zygomatic gland at the base of the fourth molar. And they discussed, well, how can we explain this, because the trigeminal nerve doesn't have autonomic fibers, so where do they come from? And they concluded that what we know, they come from the glossopharyngeal nerve and the facial nerve, and they synapse in their respective ganglions, the otic ganglion, the mandibular and the sublingual ganglion for the mandibular and sublingual salivary glands, and that facial nerve travels a bit with a branch of the trigeminal nerve, which is the lingual nerve in that case, and also the glossopharyngeal nerve, after synapsing in the otic ganglion, travels a bit with the auriculotemporal nerve, which is a branch from the mandibular nerve, which is a branch of the trigeminal nerve. And the authors concluded that because of this intimate association of these nerves with the trigeminal nerve fibers, that pathology of that trigeminal nerve could affect those parasympathetic fibers of those other nerves, and thus create deficits in their function, for instance, salivation, or maybe also lacrimation. So that's an important clinical thing we have to keep in mind in all those patients. We have to test it, so we have to do a Schirmer-Tear test. We have to look at the nasal planum to see if there's crusting or whatnot over there. And we have to look in the back of the mouth to see if there is a difference in the salivary production on one or both sides. In this case, in my dog, it was a bilateral dysfunction, and we also saw bilaterally abnormal saliva and bilateral changes in the parotid gland, not in the mandibular glands, on the MRI at least. And in this study, they didn't find, in every case, they didn't find stuff that is always explainable, because they measured also the weights of the glands in some of the deceased dogs. In one case, it was really abnormal on one side where the neoplasia was, and the other side was normal. And in other cases, they found some not so clear findings. In humans, this is a well-known thing, apparently. So parotid gland atrophy in chronic trigeminal nerve dysfunction. And it's also known as a really annoying complication at least, and it affects quality of life in patients because it affects your taste, it affects your ability to swallow, which is relevant for our patients as well. So can we conclude a diagnosis in my case? Well, we have to take into account a lot of things. We have to take into account clinical signs. We also had loss of sensation. We had salivation abnormality, and we had partial Horner, which we now can explain by the parasympathetic fiber accompaniment of the trigeminal nerve. We had enlargement on MRI, largely subjectively, maybe absolutely objectively. Contrast enhancement definitely was conspicuous. CSF protein was above reference, so would your preference go to itis or neuropathy? Treatment, which we did, was basically nothing, because there was ambiguity about, on the effect of prednisone in these cases. And so what is the outcome in this case? We did clinical follow-up. Unfortunately, the owners were sick, so we had to do that by phone and with videos they provided, and they had nice cameras, so that was not a problem. She was eating on her own. There was no more abnormal salivation, at least not noticed in the house, and there was minor loss of masticatory muscle mass. As you can see before, we have a fairly normal appearing temporal fossa here, and here we can see that it's really conspicuous. It's a slightly different angle, I know, but you can see it on other images as well, if you can appreciate that over here. And also we see that this eye shows more signs of apparently Horner, but it could also be due to atrophy of the muscles behind the eye. This is a video of the dog, which shows the recovery of jaw function. So she's able to eat, and if you pay close attention in a minute, you will see normalish saliva drooping from the mouth, which is a good sign that at least the production of saliva is still there, and it looks like it's more profuse than it was and less thick than it was. Here you can see it just dripping down like normal saliva would expect to do. So my conclusion would be that this is an idiopathic trigeminal neuropathy with salivation abnormality, and we need pathology to conclude it's an itis, because that's a pathological diagnosis to say it's inflamed. I would like to thank everyone for attending, and all my team, obviously, people at Oracle, all the authors of and especially these guys, for providing such a nice article, which is really helpful for clinical neurology as well, and all my colleagues and supervisors. Thank you very much, and I would be happy to answer any questions at this point.
Thank you, Koen. Fantastic presentation. Again, I want to reiterate that Koen is first-year resident, and you know, I think Simon and I, when we were first year, we could barely remember the 12th cranial nerve, and to have that level of knowledge is quite incredible. If you are, you know, a resident or a young neurologist, and you want to present a case like Koen has done tonight, please feel free to get in touch with us. We really want to feature, you know, young neurologists, not old bugger like Simon and I, you know, because there's so much to learn. And I think this case is a good example where with something that looks simple, like a trigeminal neuropathy, drop jaw, if you start looking carefully, there's a lot, you know, to find and a lot to learn as well. It's a good case example as well, I have to say, of what philosophy Vetorical is about. And when we created this company, Simon and I, our idea was to change from the model of the report and run. We really want this collaboration, and I think it's very well illustrated with the work with you guys in Holland. And having this two-way stream is a fantastic way for everyone to learn, and that's really what we want through this Vetorical neuroimaging reporting. So thanks a lot again for our service and for playing a great part, and we learn a lot every day. There is a lot of fantastic, I'm afraid there is no question, which I'm not surprised at all. I'm sure a lot of people have learned a lot. I will say, Koen, but if there is question about trigeminal nerve at the exam, you should be fine. Trust me.
I hope so. I hope
I will slightly worry the day you become a diplomate. I will hate to be a resident and have question at the exam made by you.
Well,
it could be a bit scary, but I've got no.
Preparing to be a pain in the ass in the future.
No, I'm sure you'll be totally fine. Simon, I don't know if there's anything else you wanted to add.
No, just thank you very much, Koen, and really to reiterate what Laurent said. I mean, it's an opportunity that we would like to provide to residents and younger members of the neurology colleges. You are definitely, as has been seen here today, the future of veterinary neurology. Like Laurent says, we've always got a lot to learn, and the best way to learn is with collaboration with people. And your obviously knowledge and enthusiasm is coming through loud and clear. So thank you very much for that. It was really articulate, well put together presentation. Hopefully that has helped a lot of people advance their understanding of some trigeminal nerve function.
There is a few questions coming out. Don't worry. I think there's a question. You can probably quickly reply to that. Can you please talk about the treatment again, or the absence of treatment?
In my case, we basically didn't do anything. I did recommend the owner to support the dog, obviously, with eating and feed it from a height, maybe with boluses of wet food, to keep it from having trouble picking it up, because that was the main problem. Treatment in the literature, they mention sometimes that prednisone was given in a few cases, and then they saw that it improved, and maybe it's logical to think that in neuritis. But there are a lot of cases, such as this one, which maybe could have neuritis, but I didn't treat it, and it improved still. So that's a thing to question. Does this patient benefit from corticosteroids or not? Maybe it would even have more masculine muscle atrophy if you give it corticosteroids and help it down. So,
in the same theme, Ricardo is asking, he has a case of lymphoplasmocytic neuritis. Do you have experience about treatment? Obviously, the question here is, the lymphoplasmocytic part, is it, the CSF, I presume, and whether or not there's any benefit in treating that.
Yeah, on my review of the literature, I only saw that once, I presume, in the review, and the first one I discussed. And they mentioned that there was a pathological confirmation of the lymphoplasmocytic neuritis. I'm not sure if that implies you have to do something different in treatment, because maybe some cases that recovered also had a lymphoplasmocytic neuritis. But basically, I don't really have experience. I haven't found that in cases I saw, at least.
No, absolutely. And the last thing, sorry, Poing. Can muscle atrophy be recovered?
Yeah, that's a good question. I don't know. My experience with other masseter muscle atrophy cases is that it is less prone to recover than other muscle types. So maybe that's the case here as well. It's obviously a good one to follow up. I try to follow up on all these cases, even months or years after. So in this case, we'll see. And I've not seen that reported on specifically in all the articles I read. but please correct me if you find anything.
What could possibly be a complication of bilateral trigeminal neuropathy, lockjaw, possibly due to muscle atrophy and fibrosis? I'll let you.
Well, the recovery phase of idiopathic stuff is usually pretty short. It's a mean of 2 to 3 weeks on the top of my head. So the masseter muscle atrophy or fibrosis, that's probably not as severe as in cases of masseter muscle myositis or whatever. So I haven't seen that as well in any of the reports that there's a locked jaw in the chronic phase or something. I can imagine if you have a really severe dysfunction in severe cases of neuritis or neoplasia, that would lead to such a situation, but it's not something that I've seen being reported.
No, I agree with you. I won't expect lockjaw. On the study by Rick Glass, the time for recovery was between 2 and 10 weeks. And, with that, you don't expect to have fibrosis and so on. So, and with a dog with a trigeminal nerve sheath tumor, there's dramatic muscle atrophy, fibrosis, but they don't get, even if it's on one side, they don't even get restricted jaw movement. The last question.
Do you use L-carnitine for support or other supplements? I didn't in this case. Would probably not be a bad idea, but I'm not sure if it will help. You could do that in every type of muscle thing, I guess. I think it's called the Shelton mix, right? L-carnitine, coenzyme Q10, and that stuff. But we do that more often in generalized muscle problems.
I agree. Fantastic. Very good. Again, and I knew you will pull it off without a doubt. That's why we wanted to give you this this platform, for you to just.
Thanks again. I'm sure that all the rest
to enjoy yourself.
Yeah. Thanks.
Again, if you are a resident, if you're a young clinician, please get in touch with us. I hope that Koen has showed you that you can enjoy yourself sharing your knowledge. We all have something to learn, so please don't hesitate to get in touch with us. Thank you again for being with us tonight. I leave the last word to Simon as well.
Yeah, no, thank you, Laurent. Thank you, Koen, for excellent presentation. And hopefully we'll see you back here again at some point in the future, no doubt. And so stay in touch. And thanks to all of the people who followed us this evening, live or not. We'll see you soon. Bye.
Have a good day. Bye-bye. Bye.